Migraine. Migraine is a complex disorder characterized by recurrent episodes of headache, most often unilateral and in some cases associated with visual or sensory symptoms, collectively known as an aura, that arise most often before the head pain but that may occur during or afterward. The term migraine is derived from the Greek word hemicrania. This term was corrupted into Low Latin as hemigrania, the French translation of which was migraine. The World Health Organization estimates the worldwide prevalence of current migraine to be 10%. The adjusted prevalence of migraine is highest in North America, followed by South and Central America, Europe, Asia, and Africa. Approximately 3,000 migraine attacks per million persons worldwide occur every day. According to the WHO, migraine is 19th among all causes of years lived with disability. Women are 3 times more likely to have migraine than men. Migraine was previously considered to be a vascular phenomenon that resulted from intracranial vasoconstriction followed by rebound vasodilation. Currently, however, the neurovascular theory describes migraine as primarily a neurogenic process with secondary changes in cerebral perfusion associated with the sterile neurogenic inflammation. A genetic component to migraine is indicated by the fact that approximately 70% of patients have a first-degree relative with a history of migraine. Typical symptoms of migraine include throbbing or pulsatile headache, with moderate to severe pain that intensifies with movement or physical activity, unilateral and localized pain in the frontotemporal and ocular area, but the pain may be felt anywhere around the head or neck. Pain builds up over a period of 1 to 2 hours, progressing posteriorly and becoming diffuse. The headache may last 4 to 72 hours. Other symptoms include nausea and vomiting, including anorexia and food intolerance, and lightheadedness, and sensitivity to light and sound. Migraine, aura may precede or accompany the headache phase or may occur in isolation. It usually develops over 5 to 20 minutes, and lasts less than 60 minutes. Aura are most commonly visual but can be sensory, motor, or any combination of these. Visual symptoms may be positive or negative. The most common positive visual phenomenon is the scintillating scotoma, an arc or band of absent vision with a shimmering or glittering zigzag border. Migraine is usually classified into several types based on the presence or absence of aura, chronicity, and other associated conditions. The diagnosis of migraine is based on patient history. Patients must have had at least 5 headache attacks that lasted 4 to 72 hours and that the headache must have had at least 2 of the following characteristics: unilateral location, pulsating quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity. In addition, during the headache the patient must have had at least one of the following: nausea and or vomiting, and photophobia, and phenophobia. Selection of laboratory and or imaging studies to rule out conditions other than migraine headache is determined by the individual presentation. Neuroimaging is not necessary in patients with a history of recurrent migraine headaches and a normal neurologic examination. Pharmacologic agents used for the treatment of migraine can be classified as abortive, that is for alleviating the acute phase, or prophylactic, that is, preventive. Acute treatment aims to reverse, or at least stop the progression of, a headache. It is most effective when given within 15 minutes of pain onset and when pain is mild. These include selective serotonin receptor agonists, ergot alkaloids, analgesics, non-steroidal anti-inflammatory drugs, combination products, and antibiotics. The indications of preventive or prophylactic medications include: frequency of migraine attacks is greater than 2 per month, duration of individual attacks is longer than 24 hours, the headaches cause major disruptions in the patient's lifestyle, with significant disability that lasts 3 or more days, abortive therapy fails or is overused. Symptomatic medications are contraindicated or ineffective. Use of abortive medications more than twice a week. Migraine variants such as hemiplegic migraine or rare headache attacks producing profound disruption or risk of permanent neurologic injury. Examples of prophylactic medications include antiepileptic drugs, beta blockers, tricyclic antidepressants, calcium channel blockers, selective serotonin reuptake inhibitors, NSAIDs, serotonin antagonists, botulinum toxin, calcitonin-related peptide inhibitors. Treatment of migraine may also include reduction of migraine triggers, non-pharmacologic therapy, and integrative medicine. Migraine is a chronic condition, but prolonged remissions are common. The severity and frequency of migraine attacks tend to diminish with increasing age. After 15 years of suffering migraines, approximately 30% of men and 40% of women no longer have migraine attacks. As per the American Headache Society, there are 5 recommendations. Don't perform neuroimaging studies in patients with stable headaches that meet criteria for migraine. Don't perform computed tomography imaging for headache when magnetic resonance imaging is available, except in emergency settings. Don't recommend surgical deactivation of migraine trigger points outside of a clinical trial. Don't prescribe opioid or butyl-containing medications as first-line treatment for recurrent headache disorders. Don't recommend prolonged or frequent use of over-the-counter pain medications for headache.